Hello and welcome. I'm Sandra Lopez, a DNP student at the Catholic University of America. Thank you for joining this project on Critline technology and dialysis. We'll explore how Critline monitoring enhances fluid management and improves outcomes. Here's what to expect. You'll complete a short pre-survey, watch a 1-hour presentation, and finish with a post-survey. A $50 stipend will be provided for your time. Please note the following disclosures. This content is for educational purposes only and does not replace clinical judgment. Treatment decisions remain the responsibility of the attending physician. Over 400,000 U.S. patients receive outpatient dialysis. Cardiovascular disease is the leading cause of death, with an average life expectancy around 5 years, just 3 years if the patient also has heart failure. Fluid overload leads to serious cardiac issues like hypertension and heart failure. Dialysis removes fluid through ultrafiltration, but removing fluid too rapidly causes low blood volume and symptoms like cramps or dizziness. Treatment aims to safely and efficiently remove excess fluid while maintaining hemodynamic stability and preventing complications such as hypotension. The primary goal of fluid management in dialysis is achieving true fluid balance, specifically balancing or aligning the rate of fluid removal with the patient's plasma refill rate. Plasma refill refers to fluid movement from the interstitial and intracellular spaces into the intravascular compartment to replace what is being removed during ultrafiltration. However, traditional assessment methods such as weight changes, blood pressure trends, and clinical symptoms cannot directly measure plasma refill. As a result, these tools often fall short in accurately determining a patient's true dry weight. The clinical practice problem under consideration is determining dry weight in dialysis patients. Determining dry weight is complex and often subjective, and traditional assessments such as weight, edema checks, and blood pressure measurements often fail to reflect intravascular volume status accurately. Fluid overload or hypervolemia increases the risk of hypertension, pulmonary edema, and cardiovascular complications. Conversely, hypovolemia can cause hypotension, dizziness, cramps, and organ ischemia, often mistaken as routine dialysis side effects rather than signs of poor fluid management. Relative blood volume monitoring with Critline technology provides real-time data to optimize fluid removal, reduce complications, and improve outcomes. Without it, treating intradialytic hypotension or intradialytic morbidities rely on reactive measures such as saline, albumin, or midodrine administration rather than addressing the root cause. Let's watch a brief video on relative blood volume monitoring, its role in dialysis, and its benefits to patients.
The kidneys are highly perfused organs that effectively and rapidly remove waste molecules and excess fluid. Filtration occurs within glomerular capillaries and forms urine. Worldwide, millions of people suffer from chronic kidney disease. This affects waste filtration and causes fluid retention, leading to around 2 million patients requiring hemodialysis. During hemodialysis, critical blood parameters such as hematocrit, relative blood volume, fluid removal by ultrafiltration, and oxygen saturation can be monitored to help limit common intradialytic symptoms such as dizziness, cramping, and vomiting. Removal of intravascular fluid during hemodialysis reduces blood volume, leading to an increase in the hematocrit. This causes a shift of interstitial fluid into the vascular space, known as plasma refill. As plasma refill occurs, blood volume increases and hematocrit decreases. Therefore, changes in blood volume and hematocrit can be used as indicators of effective hemodialysis. Critline technology can continuously and non-invasively measure these parameters to limit intradialytic symptoms. During dialysis, a Critline sensor clip is attached to a blood chamber between the arterial bloodline and the dialyzer. Optics within the sensor clip can emit multiple wavelengths of light, illuminating the blood as it passes through the chamber. This allows measurement of hematocrit, percentage change in relative blood volume, and oxygen saturation. These measurements are displayed on a monitor and updated in real time throughout the treatment. Also displayed is the patient's percent change in relative blood volume represented as profile A, B, or C. These profiles monitor the relationship between the patient's plasma refill rate and the ultrafiltration rate. Profile A is represented as a flat or slightly positive slope. This indicates that the patient's rate of plasma refill is the same as or slightly greater than the rate of ultrafiltration, suggesting that the ultrafiltration rate may be increased without the risk of immediate intradialytic symptoms. Profile B is represented as a gradual slope and has been targeted to find the best compromise between a high ultrafiltration rate and the prevention of intradialytic symptoms. Profile B indicates that the patient's plasma refill rate is slightly less than the rate of ultrafiltration, and hemoconcentration of red blood cells is increasing. The ideal slope is not a fixed percentage of change in blood volume and can vary from patient to patient. Profile C is represented as a steep slope. This indicates a rapid decrease in blood volume and significantly higher hemoconcentration of red blood cells due to a high rate of ultrafiltration, bearing a higher risk of intradialytic symptoms, which include cramping, dizziness, and vomiting. Allowing clinicians to monitor blood volume continuously throughout a treatment and make appropriate clinical adjustments in real time, Critline technology can help provide patients a more effective dialysis treatment. Critline technology provides real-time clinically relevant parameters that help clinicians to optimize fluid removal, maximize ultrafiltration, and reduce the risk of intradialytic symptoms in dialysis patients.
Please complete the pre-survey sent via text, email, or accessible through the QR code. It only takes a few minutes and your responses will help improve patient care. Thank you for completing the survey. Nearly half of hemodialysis patients are fluid overloaded, straining the heart and increasing the risk of complications like left ventricular hypertrophy and heart failure. Studies show fluid overload is linked to higher cardiovascular mortality, and traditional assessments aren't sensitive enough to detect it. Let's review some of these studies. In 2010, Agarwal studied 308 dialysis patients and found that those with minimal blood volume drop during treatment and flatter relative plasma volume slopes had a 72% higher risk of death. This suggests that chronic fluid overload increases morbidity and mortality. A 2022 study in New York City found that while hypertension is linked to fluid overload, only 48% of patients with excessive fluid were hypertensive. This highlights that fluid overload can occur without elevated blood pressure. In 2016, Hussein et al. Found that 43% of dialysis patients were still fluid overloaded despite reaching their target weight based on clinical assessments. Those with frequent blood pressure drops were more likely to be in the fluid overloaded group, showing the limitations of traditional assessments. Fluid balance is critical for maintaining organ function and health. Both fluid overload and depletion can severely impact the body. Fluid depletion lowers blood volume levels, reducing oxygen delivery to organs, which can lead to organ failure. Conversely, fluid overload strains the heart, dilutes oxygen levels, and impairs organ function. The diagram to the left shows how excess fluid affects the brain, lungs, kidneys, and other organs, highlighting the need for careful monitoring. Starling's law and Laplace's theorem explain how fluid overload increases heart stress, leading to hypotension and reduced cardiac output. Therefore, fluid overload and hypovolemia contribute to intradialytic hypotension, emphasizing the need for precise fluid management during dialysis. Intradialytic hypotension is the most common complication of hemodialysis and can lead to severe health issues including heart damage, reduced brain blood flow, gut ischemia, fainting, chest pain, and death. IDH occurs when blood pressure drops too low during dialysis, affecting organ perfusion. However, not all blood pressure crashes are caused by high fluid removal rates. so identifying the underlying cause is key for proper management. Rather than relying on reactive measures like midodrine, albumin, or saline administration, addressing the root cause allows for more effective, long-term solutions. Critline can help monitor and manage these changes. Now let's explore the evidence surrounding Critline. Real-time monitoring during dialysis helps prevent intradialytic hypotension by enabling early intervention, as shown by Stour and Keene. Studies by Preciado, Parker, and Balter highlight Critline's effectiveness in reducing hospitalizations and mortality rates. Additionally, research shows improvements in blood pressure, reduced antihypertensive use, and lower ESA doses with proper fluid management. Integrating Critline into practice enhances safety, reduces hospitalizations, and improves outcomes. We have reviewed multiple studies demonstrating Critline's benefits in reducing hospitalizations, improving survival, and enhancing blood pressure control. However, one study presents a different perspective. The CLIMB trial by Redden et al. In 2005 reported higher hospitalization and mortality rates among Critline patients. Excessive fluid removal and poor protocol adherence, particularly in CHF patients, may have skewed CLIMB's findings. In practice, individualized removal rates, typically around 4% blood volume change per hour, ensures safer treatment. Despite CLIMB's findings, extensive evidence supports real-time monitoring like Critline for safer, more effective dialysis care. Rodriguez et al. In 2005 found that using Critline to monitor blood volume helped adjust dry weight more accurately. Of 28 patients, 19 had their dry weight lowered, indicating excess fluid, while 9 had it increased, suggesting that they were too dry. This approach improved fluid management when combined with clinical judgment. Understanding plasma refill and compartment shifts helps clinicians guide fluid removal. Jabara et al. Showed that without ultrafiltration, relative blood volume monitoring can detect fluid shifts from the extracellular to the intravascular space. In the graph to the left, the rising RBV curve indicates plasma refill, while the graph to the right shows a flat RBV curve with no refill in the absence of ultrafiltration. Now here's the question. If plasma refill occurs, will the hematocrit go up or down? As fluid enters the bloodstream, it dilutes the blood, reducing hemoconcentration and causing the hematocrit to drop. Why is this important? If blood pressure is low and refill is present and we can detect it, we can safely continue to remove fluid, the blood pressure will likely improve, and the patient will not experience any symptoms. If no refill is present, even with a normal blood pressure, the patient is at higher risk for intradialytic symptoms. Critline tracks these real-time changes, helping guide safe fluid removal. Critline technology allows continuous monitoring of SaO2, arterial oxygen saturation, and ScVO2, central venous oxygen saturation, during dialysis. Studies show that lower intradialytic SaO2 or ScVO2 levels are linked to poor outcomes. Chan et al. Found a connection between lower ScVO2 and shorter survival, while Meiring-Woston et al. Showed that prolonged hypoxia, SaO2 less than 90% for one-third of treatment, reduces survival probability, as seen in the Kaplan-Meier curves shown here. Low blood oxygen levels, also known as hypoxemia, affect 56% of patients and can lead to a lack of blood flow to organs, low blood pressure, and accompanying symptoms like chest pain. When oxygen levels drop, the body releases adenosine, dilating blood vessels, lowering blood pressure, and potentially harming the heart or other organs. Now we'll watch a video that walks through the use of Critline from setup and initiating treatment to reviewing oxygen saturation graphs, performing a plasma refill check, setting event markers, and properly ending a treatment.
Verifying the click device. The click device features a verification filter that is unique to each click device. The verification filter is used to verify the accuracy of the click device. The click verification filter is attached to the click device's USB cable. The click device should be securely clipped to the verification filter when it is not in use. When the click device is stored on its verification filter, the 2008T hemodialysis machine automatically verifies the accuracy of the click device when entering the dialysis mode. If the click device is not stored on the click verification filter, the device must be verified manually at least once per month. To manually verify the click device, place the sensor clip on the verification filter. Select the Verify Critline button from the Test and Options screen when the 2008T machine is in the dialysis mode. Press the Confirm key. Verification can take up to 1 minute. When X appears in the OK field, the click device has successfully verified its calibration and is ready for clinical use. In the event that the verification fails, the status bar will display Verify Failed, and this click device cannot be used for the dialysis treatment. Disconnect the click device from the USB port and press the reset key to disable the click device and contact a qualified service technician. Connecting the Critline blood chamber and click device. The click device utilizes a sensor clip which is placed on a blood chamber that is attached to the dialyzer. Proper alignment of the blood chamber and placement of the sensor clip is essential to obtain accurate readings. Do not use the Critline blood chamber if its package has been opened or sterility has otherwise been compromised prior to use. The viewing area of the blood chamber should be kept clean and free of obstruction. During setup of the extracorporeal circuit, aseptically attach the blood chamber to the arterial end of the dialyzer by removing the cap from the arterial header of the dialyzer and the red cap from the blood chamber. While holding the blood chamber securely in one hand, aseptically attach the blood chamber to the arterial end of the dialyzer. Make sure the connection is tight without using excessive force. Be careful that you do not cross-thread the connection. You are now ready to attach the other end of the blood chamber to the arterial bloodline. If your organization is using Combiset SmartTech bloodlines, follow your facility's procedure when preparing bloodlines and partially insert the blood chamber into the arterial port of the dialyzer. Gently twist the blood chamber counterclockwise until it drops into place. It is important to make sure the blood chamber drops into place before tightening. You should be able to see and feel the blood chamber drop into the dialyzer connection. After the blood chamber drops into place, twist clockwise by using the blood chamber wings to tighten the connection. Make sure the connection is tight without using excessive force. Continue with bloodline setup per your facility protocol. Ensure that no air is in the blood chamber after priming. Any air present in the chamber will cause the hematocrit reading to be inaccurate. Once treatment has been initiated and blood has been flowing through the blood chamber, attach the sensor clip to the blood chamber by squeezing both sides of the sensor clip apart. Place the sensor clip over the blood chamber so the optical sensors cover the lens of the blood chamber. You will hear an audible click. To ensure proper alignment, ensure that the sensor clip is perpendicular to the top of the dialyzer. Initiating treatment. To prevent air bubbles from entering the blood chamber, ensure that all connections are tight. To detect air bubbles, look at the viewing area of the blood chamber. They will be clearly visible if present. If no air bubbles are present, the entire viewing area of the blood chamber will be filled. To remove any air bubbles, while holding the blood chamber vertically, gently tap on the chamber until all air bubbles exit the viewing area of the chamber. Follow the instructions for entering patient-specific treatment parameters and options as per your facility protocol. Initiate the treatment on the hemodialysis machine by selecting the Treatment Paused button and then pressing Confirm once the proper blood flow is achieved. Graphing of the data begins after the click device reads blood sensed and the hematocrit has been stable for 60 seconds with the treatment clock and blood pump running. Graphs are displayed for a minimum of 4 hours, the set default, and a maximum of 10 hours. Let's take a few moments to familiarize ourselves with the Critline screen. You will immediately notice that most of the commonly viewed data from other screens are grouped on the screen for convenient monitoring. All treatment parameters from the home screen are displayed just above the screen access buttons on the Critline screen so that the operator may primarily use this screen during the treatment. The Critline screen can display either blood volume or hematocrit on the upper graph, depending on the service mode setting. The graph just below the profile graph is the oxygen saturation graph. This can be changed by the operator to display blood pressures by selecting the graph and pressing the Confirm key. Simply touch the graph and press Confirm to return to the oxygen saturation graph at any time. Let's review an example of a blood volume graph. The horizontal axis is in 1-hour increments. The screen will rescale if the treatment goes longer than 4 hours. The numbers on the vertical axis represent the percent change in blood volume. Every patient begins at 0%. Fresenius Renal Technologies has introduced Critline profile boundary guidance designed to deliver clear visual markers of key blood volume rates. The profile boundary lines are intended to provide accurate, real-time data to help guide ultrafiltration decisions. These lines can be activated or deactivated anytime during treatment by pressing the Boundary Lines button on the Critline screen. Please note, when using this feature, the Critline profile box is no longer visible. We will review these boundary lines in further detail later in this video presentation. The row of text directly above the blood volume graph shows data that continuously displays the elapsed time since the start of the treatment, the initial hematocrit, and initial estimated hemoglobin. The column immediately to the right of the graph displays the current profile letter based on the previous 15 minutes, A, B, or C, hematocrit, the current estimated hemoglobin, the cumulative percent change in blood volume, current oxygen saturation, and minimum oxygen saturation since the start of the treatment. These values are updated throughout the treatment. The far right column displays the treatment clock, blood volume and oxygen alert level buttons, and the markers buttons available to the operator. Setting blood volume and oxygen saturation alert levels. The click device has user-adjustable alert levels for a blood volume alert and an oxygen saturation alert. The blood volume alert level allows the caregiver, under physician direction, to enter a specific blood volume level. When the current change in blood volume percentage change drops below the set blood volume alert level, the 2008T hemodialysis machine stops the ultrafiltration pump and displays the alert message, "Rel blood volume low." This message will occur until the user changes the level or sets the blood volume alert level to off. To set the blood volume alert level, select the BV Alert Level button and enter the desired value using the up or down arrow keys or the numbers on the keyboard and press the Confirm key. To turn the BV Alert Level off, enter the number 0 on the keyboard and press the Confirm key. The blood volume alert level can be set from -1 to -20 or 0% or off. The default setting is -15%. The alert level is drawn as a blue dotted line across the blood volume graph. If the actual reading reaches the alert level, the 2008T hemodialysis machine will stop the UF pump and an audible alarm will sound. The oxygen saturation alert level is designed to alert the user when the oxygen saturation level in patient blood volume drops below the set oxygen saturation percentage. When the current oxygen saturation value drops below the set oxygen alert level, the alert message "Oxygen saturation low" is displayed in the status box. The alert can be cleared when the oxygen level increases above the alert level, the user changes the alert level, or the user turns the alert level to off. To set the oxygen alert level, select the O2 alert level button and enter the desired value using the up and down arrow keys or the numbers on the keyboard and press the confirm key. To turn the oxygen alert level off, enter the number 0 on the keyboard and press the confirm key. The oxygen alert level defaults to 89% and can be set from 45% to 95%. Setting the alert level to any value 44 or lower turns the alert level off. Oxygen saturation graph. Now, let's review the oxygen saturation graph. Again, this graph indicates the patient's oxygen saturation throughout the treatment. The normal value for arterial oxygen saturation from a fistula or graft is greater than 90%. The normal range for venous oxygen saturation from a venous catheter is between 60 and 80%. If the oxygen saturation level is too low, this may be an indication that the patient is not tolerating the dialysis treatment. Follow facility protocols regarding patient reassessment and intervention. Blood volume profiles. With the ultrafiltration rate above minimum, a flat or positive profile where the blood volume reduction is less than 3% per hour indicates that the patient's plasma refill rate is occurring at the same or a greater rate than ultrafiltration. This is a profile A. Profile A suggests that the ultrafiltration rate may be increased without immediate risk of intradialytic symptoms. Please note that a profile A might be acceptable in some patients, but not others. Therefore, the clinician should always assess the patient's condition before making any interventions. The Critline screen also displays a trending blood volume profile in the form of a letter, A, B, or C, once 15 minutes of data is obtained. This trending profile letter is based on a rolling average of the previous 15 minutes of data and is not to be used solely when determining a patient's status. More information on how to use this trending blood volume profile letter to assess your patient will be provided by your Critline trainer. In the example here, the profile begins to decrease gradually. A gradual slope where the blood volume reduction is between 3% and 6.5% per hour has been targeted to find the best compromise between a high ultrafiltration rate and the prevention of intradialytic symptoms. The ideal slope is not a fixed percentage of blood volume decrease and will vary from patient to patient. This is considered a profile B. A steep slope, where the percentage of blood volume reduction is in excess of 6.5% per hour, represents a rapid decrease in blood volume that has a higher risk for intradialytic symptoms like cramping and/or hypotension. In this example, profile C starts to develop at approximately the half-hour mark. This is considered a profile C. Now that you have a solid understanding of the definition of Critline profiles and the value of this data, let's quickly revisit the boundary line guidance feature. As we addressed earlier in the presentation, the Critline profile boundary guidance is designed to deliver clear visual markers of key volume rates. They are intended to provide accurate, real-time data to help guide ultrafiltration decisions. The top line identifies a relative blood volume reduction of 3% per hour, or the reduction rate associated with the Critline profile A. The bottom line depicts a blood volume reduction of 6.5% per hour up to negative 15%. This reduction rate is associated with the profile C. Let's take a moment to review the area between these lines. This area is associated with a relative blood volume reduction between 3.0 and 6.5% per hour and aligns with the Critline profile B. Plasma refill check. Let's review how to perform a plasma refill check. Anytime the ultrafiltration rate is minimized, you can check to see if plasma refill is present. In this example, the black intervention marker indicates that the UF was set to minimum. During the next several minutes, you see the blood volume profile has increased significantly. This means that the patient is continuing to refill into the vascular space and has more fluid to remove. To do a refill check, follow these steps. Set the UF rate to minimum of 300 milliliters per hour. Record the current hematocrit value. Wait 10 minutes, then record the current hematocrit at that time. If the hematocrit is decreased by 0.5 or more during the 10 minutes, the patient is considered to have vascular refill. Setting an event marker. The click device is designed to allow for the notation of an event during a treatment. An event marker can be placed on the blood volume, hematocrit, or oxygen saturation graphs during the treatment to note a symptom or intervention. To enter an event, press the Markers button to open a text box for symptom or intervention markers. Use the up or down arrow keys on the keyboard to select the appropriate marker. Use the symptom mark to place a yellow diamond and the value on the graph to indicate a patient's symptom at that time. Press Confirm or Cancel as appropriate. Use the Intervention mark to place a black triangle and the value on the graph to indicate that an intervention was done by the clinician at that time. Press Confirm or Cancel as appropriate. Please note that markers can only be set when the treatment clock is running and the click device is enabled. It is important to note that markers can only be set at a minimum of 10-minute intervals. Resizing the graph may cause markers to rotate in order to better fit the space available. The system will not place a marker if there is not enough space to properly display. Ending a treatment. At the end of the treatment, when the remaining time on dialysis or RTD timer has counted down to 0, the treatment clock is paused, a warning alarm sounds, and the message RTD equals 0 appears in the status bar. Pinch the click device and gently remove the device from the blood chamber. Store the click device by clipping it to its verification filter. Follow the instructions as outlined by your facility policy to return the blood to the patient. Discard the disposable blood chamber with the rest of the blood lines per facility protocol.
The following study presents a recorded 5-hour dialysis treatment enhanced through video acceleration to illustrate how Critline functions in clinical practice.
Let's take a moment and review the medical history of patient 1. Patient 1 is a 52-year-old African-American male with type 2 diabetes. He is legally blind. He has a right below-the-knee amputation and wears a prosthetic leg. He underwent a left fifth toe amputation secondary to gangrene. Hemodialysis was initiated in 2001. He undergoes a 5-hour treatment via permacath with a consistent history of cramping during the last 30 to 45 minutes of treatment. While non-compliant with treatment for many years, he has not missed a treatment in over 4 years. He lives independently at home with maximum home care services. Let's quickly review some key pre-treatment data. Patient 1's estimated dry weight prescription is 101.50 kilograms. Pre-weight was 101.60 with a last post-weight of 100 kilograms. The clinical team set the initial ultrafiltration goal for 1,200 milliliters, with an ultrafiltration rate of 240 milliliters per hour for the 5-hour dialysis treatment. At the start of dialysis, patient 1's initial blood pressure was 176/107. Readings from the Critline monitor indicated an initial hemoglobin of 12.4 and starting hematocrit of 36.4. During this treatment, the nurse requested a physician order to administer oxygen via nasal cannula based on long history of consistent cramping during last 30 to 40 minutes of treatment. 21 minutes of treatment time has elapsed for patient 1. If you look at the screen, you will notice the following. The letter C is shown in the profile letter box in the right top corner. However, when you look at the full picture of patient 1's machine screen, you will notice the blood pressure is 158/90. Heart rate is 94. The percent of blood volume change is -2.6% and the slope is flattened out. Although it says the patient is in a C profile, the patient is stable, so no interventions are necessary. As we continue to observe over the next several minutes, you notice the percent of blood volume change is continuously fluctuating between -0.8% and -3.2%. The trending profile letter has changed as well. Originally a C, but then to a B, and now an A, which would be the appropriate indication that the patient's plasma refill rate is exceeding the set ultrafiltration rate programmed. After getting the remainder of her patients on the machine, the caregiver has returned to patient 1's chairside. Based on the assessment of the patient, blood pressure of 158/90, heart rate of 94, and a blood volume percent change of -1.2%, an increase of 200 milliliters was added to patient 1's goal. This will bring it from the initial goal of 1,200 milliliters to 1,400 milliliters. "10 minutes have gone by, and you will still notice that despite increasing patient 1's ultrafiltration goal by 200 milliliters, the percent of blood volume change is still fluctuating between -0.6 and -1.9%. A second intervention is made. Another 200 milliliters is added to patient 1's ultrafiltration goal, bringing the total ultrafiltration goal to 1,600 milliliters. After this increase of an additional 400 milliliters per hour, the percent of blood volume change continues to fluctuate. This indicates the patient is refilling their vascular space faster than the set ultrafiltration rate. Now, a full hour into treatment, we notice not much has happened with his percent of blood volume change. It continues to fluctuate, and the slope continues to be in a flat position. This indicates that the patient's plasma refill rate continues to exceed the set ultrafiltration rate. A half hour from the last intervention has passed. Based on patient 1's assessment, blood pressure of 175/99, heart rate 93, and previous percent blood volume change, the caregiver decides to increase the goal by another 200 milliliters to a total of 1,800 milliliters per hour, hoping to optimize fluid removal. For a short time, it appears we are gaining momentum in removing fluid based on the percent of blood volume change fluctuation between -1.7% and -3.7%. However, we learn quickly this is short-lived. For timing purposes, the film is speeding up quite quickly. However, if we look closely enough at patient 1's percent of blood volume change, you will notice that even after 1 hour and 25 minutes into treatment, patient 1 remains in a positive fluid balance. In the last 10 minutes, you notice another intervention marking on the screen. The percent of blood volume change is -0.7%, but the caregiver did not make an increase in the goal. Since it was only 10 minutes after the last increase and the blood pressure had decreased to 144/93, it was decided to wait until the next blood pressure check to intervene. Throughout this waiting period, however, patient 1's percent of blood volume change is still fluctuating between a positive and a negative fluid balance. A fourth intervention was completed, adding an additional 200 milliliters to patient 1's goal. This has added an additional 800 milliliters to patient 1's ultrafiltration goal. Please note, the profile letter box in the upper right-hand corner shows an A profile, and patient 1's percent of blood volume change indicates such at -0.5%. We see very little change in fluid shift at this time. The blood pressure has increased to 179/109 and heart rate 92. No interventions were completed due to timing as per the facility protocol. Here we notice patient 1's percent of blood volume change is fluctuating between a positive and negative percent. You see patient 1's blood pressure decreased to 132/86, heart rate 94. Patient 1 is resting comfortably and has no complaints. After assessing patient, the caregiver decides to increase the ultrafiltration goal by 200 milliliters. The percent of blood volume change is at -0.2% after 2 hours of ultrafiltration, indicating an increase is necessary. This increases the total ultrafiltration goal by 1,000 milliliters from the initial goal of 1,200 milliliters. When observing the slope, you may notice a slight sharp decrease for a very short time. The profile letterbox has changed to show a C. However, there is no indication patient 1 needs an intervention. The blood pressure is stable at 159/102, heart rate 94, and the percent of blood volume change is -2%. Patient 1 is sleeping. New blood pressure value shows 133/99, heart rate 95, and percent blood volume change is minus 2.4%. No intervention is needed. Based on the newest blood pressure reading of 146/77, heart rate 93, 30 minutes later, another 200 milliliters was added to patient 1's goal. After 3 hours into patient 1's treatment, we are finally seeing a consistent percent of blood volume change. This is a total of 1,200 milliliters added to the initial goal set when patient 1's treatment began. Even with an increase of 1,200 milliliters per hour to the initial goal, patient 1 still shows fluctuation in his percent of blood volume change. Patient 1's slope is heading in a downward spike. The blood pressure is 144/96, and we are successful in getting to a minus 5% blood volume change, but not for too long. As we watch the blood pressure decrease slowly to 132/84, we can still notice the percent of blood volume is still fluctuating. This is a clear indication that patient 1 still has continual plasma refill. After another 30-minute interval, the caregiver decided to increase the ultrafiltration goal by another 200 milliliters. This is 1,400 milliliters more than the initial goal set at the beginning of patient 1's treatment. Another blood pressure value is taken at this time. Blood pressure remains stable at 148/76, heart rate 91. He is resting with no complaints. Here we see a shift in the screen. Because patient 1's treatment is 5 hours, you see the treatment screen rescale to allow for the 4th hour. Again, this has no effect on the patient's treatment. We are almost into the 4th hour of patient 1's treatment. Blood pressure is decreased to 120/74, heart rate 93. The ultrafiltration rate currently is 730 milliliters per hour. However, the percent of blood volume change is still sitting at -4%. Patient 1's blood pressure is the lowest it's been throughout the treatment. There is no sign of instability, and patient 1 reports feeling okay. Based on current blood pressure reading, the caregiver decides to just observe patient 1 and check his blood pressure every 15 minutes rather than every 30 minutes. Patient 1's blood pressure rebounded and is now at 129/74, heart rate 92. Based on patient 1's assessment, the caregiver decided to increase patient 1's ultrafiltration goal by 100 milliliters. Five minutes after the last increase, you see the percent of blood volume change increase to -5.5%, which is what we have been waiting to see. The slope, however, is heading in a downward spike, and the profile letter box shows a C. Based on patient 1's assessment, the caregiver did not decrease the goal, but rather observed patient 1's slope and percent blood volume change for a rapid decrease. After 4 hours and 35 minutes into patient 1's 5-hour treatment, the blood pressure is 129/38, heart rate 93. The slope that was heading in a downward spike has leveled out once again, and the percent of blood volume change is -6.6%. Patient 1's treatment screen rescales again to accommodate the long treatment time of 5 hours. Again, there is no impact on the patient's treatment. Current hematocrit is 38.8, hemoglobin is 13.2, and we see a 6.2% reduction in blood volume at this point in the treatment. While the trending profile indicates an A profile, patient 1's refill has decreased steadily, as evidenced by the steady reduction of blood volume percentage. Blood pressure has increased to 139/77. At the end of patient 1's treatment, his blood pressure is 135/63, heart rate 93. Patient 1 is feeling well at the end of his treatment. He has experienced no cramping as he has done every treatment in the past. We achieved a -7% blood volume change. Let's review some of the lessons learned from patient 1. Without access to the data from the Critline monitor, the clinical staff would not have had the information to adjust treatment to remove 2,603 milliliters of fluid, 1.4 liters above the initial ultrafiltration goal set. The Critline data suggests that the initial goal might not have been set correctly. Initial ultrafiltration goal calculation is an extremely important step in effective fluid management. The ultrafiltration goal was challenged per facility protocol. However, based on nurse assessment, the staff were able to secure an order and successfully challenge patient. Clinicians were able to rely on the percentage change in blood volume in real time to assess this patient's ultrafiltration tolerance. So, when the blood pressure decreased to 111/79, the staff were comfortable to change the frequency of blood pressure monitoring rather than reducing ultrafiltration goal or administer saline. Without access to Critline data, staff would not have been able to assess fluid status throughout treatment. Strong clinical evidence supported the change in EDW prescription.
In summary, Critline enhances dialysis care by providing real-time insights into patient tolerance, optimizing fluid removal, and preventing complications. By integrating Critline, we improve safety and effectiveness in dialysis. Stay until the end for the post-survey QR code. Your feedback is invaluable. Here are the key resources used in this presentation. And this concludes my presentation on optimizing fluid management in hemodialysis using Critline technology.